Section 3, Course of PTSD and Other Negative Consequences. Now, the majority of empirical investigations of older adult trauma survivors are cross-sectional and retrospective, and there are few longitudinal studies that have followed younger or middle-aged adult trauma survivors well into adulthood. What we've talked about earlier is that there's quite a limited information on the longitudinal course, and what has been done on combat veterans and former prisoners of war. There's one data set that I just hats off to. I'm so excited by. It's not an epidemiological investigation, but I think it speaks to this incredible former prisoner of war population. And these two psychologists, Zeiss and Dickman, in 1989, published a paper. Shortly before that, they had gone to a small former prisoner of war meeting, handful of guys, and they assessed their PTSD and they asked them about what their PTSD had been like across their lifespan. And these former prisoners of war, who were so used to not receiving the attention that they needed and deserved, copied these handouts and sent them across the country to over 400 of their friends, who sent them back to these psychologists. And we found that the longitudinal course seems to be that about 20% of people are continuously troubled, about 20% are symptom-free, and the vast majority, 60%, experience intermittent symptoms, which wax and wane across the lifespan. In addition, there was some interesting research by some psychologists in Minneapolis, Cynthia Port, Brian Engdahl, and Fraser, in 2001. And they had an investigation where they obtained retrospective recall, and they asked these former prisoners of war to tell them how they had been feeling across the lifespan, and then they followed them longitudinally a bit over time. So it was sort of a crossbreed of a study. And they found that the older former prisoners of war reported an immediate onset and then a gradual decline of PTSD symptoms after the war, followed by a higher return of higher rates of PTSD in later life. Now, more recently, there has been a number of population-based cohort studies focused on those who served in the Vietnam War. And these are really important because they give us information on adult development, trauma, and aging. And despite the differences in methods and measures and diagnostic criteria used, the vast majority of the studies converge to indicate that only a substantial minority continue to have significant mental and physical health problems decades after the war. Now, one of my favorite, and for many people their favorites, one of the most significant contributions to the study of adult development was the National Vietnam Veterans Readjustment Study, and its more recent 25-year follow-up, the National Vietnam Veterans Longitudinal Study. In response to a congressional mandate in the early 1980s, researchers, Kolka et al. In 1990, obtained detailed information about the psychological impacts of war and demonstrated that a significant number of Vietnam veterans were experiencing PTSD and other life stressors, such as marital and work-related stressors. So in that large data set, they found at the time, decades ago, that 15.2% of male and 8.5% of female Vietnam theater veterans had current PTSD. Now, in over the 25-year follow-up, the PTSD symptoms had remained fairly stable, with 16% of combat-exposed veterans reporting an increase in PTSD symptoms, and only 7.6% reporting a decrease. And this is from Charlie Marmar et al. In 2015. I think it's really important for us to know that many of the participants in the NVVRS, at least 20% of those participants, had died over the 25-year span. Thus, the mortality rates may have impacted these findings. In addition, the long lengths of time, not that they're not two incredible data sets, they absolutely are, but that 25-year time period between the two data collection points may not accurately represent the intricacies of the trajectories, including the remitting and relapsing patterns of symptoms. While most Vietnam theater veterans had low PTSD at both time points, it's important to note that a significant minority were symptomatic 4 decades after the war. Now, we're not exactly sure what predicts the ebb and flow of PTSD symptoms across the lifespan. Many of us have guessed and imagined and hypothesized that an increase in symptoms may be due to life changes and losses that come in old age. With advancing age, there may be increased risk for medical illness, decrements in functional status, bereavement, retirement, changes in social and familial roles, and a general loss of control, as well as more time for reflection. Many of the older adult veterans in particular that I've worked with have talked about working 2 and 3 jobs to keep PTSD symptoms, including difficulties sleeping and concentrating, at bay, and that when they find that they have more time on their hands and friends and family members have died and they have less social support, they see that increase. Since the introduction of the diagnosis of delayed onset of PTSD, which requires that the onset of symptoms occur 6 or more months post-exposure, there's been some controversy about its existence. There have been at least 22 published clinical accounts illustrating what is thought to be late onset PTSD in older adults. Again, this focuses primarily on males who experience trauma. But to be provocative, I think it's important for us to think about, is it delayed onset or is it delayed recognition? In addition, is this partial PTSD that worsens over time? Although delayed onset of PTSD has been empirically verified, it appears to be rare in the absence of any other symptoms. Thus, it's more likely to represent subthreshold PTSD that worsens over time, or delayed onset PTSD in older adulthood might more accurately be labeled delayed recognition. There is some interesting work by some folks at the Boston National Center for PTSD. Eve Davison et al. In 2006, and Linda and Dan King, Vickers, Davison, and Ron Spiro in 2007, and later by Davison and colleagues in 2016. And what they did is they reported a phenomena they termed originally late onset stress symptomatology, or loss, which has more recently been reconceptualized and renamed as later adult trauma reengagement. And this also may be similar to late onset PTSD. These terms have been posited to apply to older veterans who were exposed to combat in earlier adulthood and had no difficulties in trauma-related functioning throughout their lives, who then go on to have trauma-related symptoms for the first time in old age. And the thought is not just that they have the elevation in symptoms, but that our approach in treatment should be different as well, towards more of a reworking and sort of a narrative life review. The empirical investigation for this construct is required. We also need more studies to differentiate it from delayed onset PTSD, and we need to test its applicability to other older adult trauma populations, not only or solely primarily veterans. Now, the overwhelming majority of studies on older adult trauma survivors focus on PTSD, while traumatic exposure, as you and I know, has been repeatedly associated in children, adolescents, and younger adults with additional mental health consequences, such as depression and substance abuse. We simply don't have these investigations, unfortunately. In a large epidemiological investigation, Raposo et al. In 2014 found that older adults who experienced childhood adversity had higher odds of having mood, anxiety, and personality disorders in later life. Similarly, in a very small study, but a very interesting study of low-income older adults living in public housing, Larkin et al. In 2017 looked at adverse childhood experiences in this population and found that the ACEs score predicted the likelihood of substance use history decades later. Over half of the older adults who had an ACEs score of 4 or more experienced substance abuse in their lifetime. So PTSD and suicidal risk. Well, unfortunately here we don't have as much good data as we'd like to either. Lots of opportunities for researchers to do this work. The full spectrum of suicidality, including suicide plans, attempts, and completed suicides, have received little scientific study in older adult trauma survivors. A few investigations are really worth noting. For example, in a population-based, nationally representative sample of community-dwelling older adults aged 50 and older in England, childhood sexual abuse was significantly associated not just with mixed anxiety and depression, generalized anxiety, eating disorders, and PTSD, but it was also significantly associated with suicidal ideation. In that sample from 2012, in addition, both childhood sexual abuse and sexual abuse re-victimization were related to psychiatric hospitalization, and sexual re-victimization was related to consultation of general practitioners for mental health, as well as outpatient clinic visits. In a large investigation of over 17,000 veterans aged 65 and older, those with PTSD, whether it was some PTSD and having partial PTSD or full PTSD, those folks were significantly more likely to report general health problems, as well as report little or no social support, as well as have higher rates of death wishes and suicidal ideation than those with no trauma history or those with trauma but no symptoms. And that's work done by Durai et al. 2011. In a nationally represented sample of over 1,600 people aged 60 and 85 in Germany, Glaser and Bowler 2012 found that suicidal ideation was associated with higher number of traumatic experiences and a higher prevalence of PTSD than those without suicidal ideation. Now, if we look at PTSD and functional impairment, this is an interesting relationship. As adults reach old age, their functional limitations typically increase. They have decreased mobility and diminished sensory capacities, as well as their occurrence of medical illness and other negative health consequences also rise. But even in this population, we see exposure to trauma throughout the lifespan has been linked to a higher likelihood of global disability. In a number of data sets, older veterans with PTSD had poor health functioning and increased disability, and that's published in Goldberg et al. 2016. Similarly, in Byers et al. 2014, older adults, not veterans, older adults with persistent PTSD were 3 times more likely to have any disability. This means a decrement in their role functioning, their mobility, their cognition, and their social functioning. Similarly, in Rob Pietrzak's work, Pietrzak et al. 2011, older adults with PTSD reported lower psychosocial functioning, bodily pain, vitality, and lower physical functioning. An interesting study done by Baker et al. 2009 found in a sample of women that prior year physical abuse, verbal abuse, or both abuse types, those individuals had poor physical and mental health and physical and social functioning. We have some information, although not enough, on PTSD and social or relationship difficulties. In particular, some of this data comes from a study that my colleagues and I published out of data on former prisoners of war. We published this at Cook et al. In 2004, and that PTSD was associated with poor marital adjustment and communication with spouses and more difficulties with intimacy. And that is that older adults who were in World War II, prisoners of war in both the European and the Pacific theater, decades later reported that their marriage was negatively impacted. How sad is that? Some of the key work on PTSD and physical health has been done specifically in older adult populations. Paula Schnurr, the executive director at the National Center for PTSD, and Ron Spiro at Boston University and the National PTSD Center in Boston in 1999, and Schnurr and Spiro in 2000, published some seminal work. Essentially, they found that older adults were saying via self-report that those who had significant PTSD symptoms also reported poor physical health. And this was a relationship that was not mediated by smoking or alcohol use. When Schnurr and Spiro went and looked in the medical records of these patients, they found that those with PTSD had more physician-diagnosed disorders. That is, PTSD was associated with arterial, lower gastrointestinal, dermatological, musculoskeletal disorders, meaning for trauma survivors, the sickness isn't just in their head, but it's actually diagnosed on paper by their physicians. Now, there's some interesting research on older veterans and showing that those with PTSD receive less mental health services. In a small regional study done in the Northwest US, older veterans who screened positive for PTSD in primary care had low rates of receiving adequate treatment. And how they defined adequate treatment in Liu et al. 2012 was as having 9 or more specialty mental health care visits in the year following the positive screen. Now, at least 2 studies in large national databases have confirmed these findings. Doran et al. In 2017 found that older veterans with PTSD received fewer therapy sessions and were less likely to receive an adequate dose. Similarly, my colleagues Noel Smith in Smith, Cook, Peterzak, Hoff, and Harpaz-Rotem in 2016 found that in this large data set of older veterans, 3/4 of older veterans who were recently diagnosed with PTSD, although they received some type of mental health treatment, older age was associated with decreased likelihood of receiving mental health care, longer periods of time before their first appointment, fewer psychotherapy appointments, and decreased likelihood of receiving antidepressants and combination treatments. We simply must do better, whether that means educating the public and the veterans that their symptoms are legitimate and understandable and they deserve treatment, or if it's educating the providers in primary care to send their veterans to specialty mental health care. PTSD and cognitive impairment and accelerated aging in older adults. Let's talk about that for a few minutes. A systematic review was conducted on 24 studies on the prevalence, incidence, and patterns of neurocognitive and psychiatric comorbidities among older veterans. And this was work done by Kang et al. In 2018. These studies were quite diverse, with samples coming from the US, Australia, and the Netherlands. Some were cross-sectional, while some were retrospective and others prospective. But there's also some data now in that data set that were not just from clinical and epi, but were from community samples. And the risk for dementia was higher in veterans with PTSD than in those without. These findings are consistent with 5 retrospective cohort studies based on veterans and VA administrative data. Now, there has been a little bit on civilian populations. One of these occurred outside of the US in Taiwan, namely Wang et al. In 2016. Examined the incidence of PTSD in dementia in a very large data set and found that in adults age 45 and older with a diagnosis of PTSD, they had a 4.37-fold higher risk of dementia compared to matched controls, even after accounting for demographic variables and medical and psychiatric diagnoses. Now, in a civilian data set, in another investigation here in the US in a Northern California healthcare system, Flat et al. In 2018 examined the association between PTSD and dementia in men and women 60 years old and older. And through electronic medical data from almost 500,000 members, we found that there was an association that older adults with PTSD had a 73% increase in risk of dementia compared to those without a diagnosis. Hopefully, more research will be continued to be done in this area. One area that I'm super excited to see some investigation is the relationship between interpersonal violence and cognitive consequences in later lifehood. Interpersonal violence, can involve sustained repetitive assaults to the head and the face, including violent shaking and strangulation. There have been a few studies that have looked at the difficulties that occur because of IPV and how that might be related to one's ability to concentrate, to shift their focus of attention, as well as deficits in problem solving. There was a very small study of older women with probable Alzheimer's disease referred to a memory disorder clinic. And this group, Luang et al. In 2006, found that 17.5% reported spousal abuse with head trauma. That is, being struck in the head 5 or more times and losing consciousness on 2 or more of the occasions. We need to be looking at this in future investigations. Now let's talk about the impact of trauma and PTSD on accelerated aging. Lohr and colleagues in 2015 conducted a comprehensive review of published empirical studies relevant to early aging and PTSD. They found 6 studies confirming biomarkers of senescence, such as reduced telomere length and pro-inflammatory markers in PTSD. In addition, they noted that there was a substantial evidence showing the increased medical comorbidity among several targeted conditions known to be associated with normal aging, including cardiovascular disease, type 2 diabetes, gastrointestinal ulcer disease, and dementia. And lastly, they found 7 of the 10 studies reviewed indicated PTSD to be associated with earlier mortality. They concluded that there is evidence then suggesting that PTSD is associated with a phenotype of accelerated senescence. More specifically, in a study by Roberts et al., 2017, telomere shortening has been linked to accelerated aging, early chronic disease development, and death. And lastly, some fascinating work by Erica Wolf and colleagues in 2016 and beyond, where she examines one strong metric of cellular aging, DNA myelination, which is an epigenetic mechanism used by cells to control gene expression. She found a very strong relationship between this and PTSD.